Should I start?
So let me introduce. Good afternoon, everyone. On behalf of IIP Central Delhi City Branch and BLK Centre for Child Health, I extend a warm welcome to all of you to this BLK Telepeds webinar on bridging life and liver, understanding liver transplantation in children. We understand liver transplant is a complex procedure and it is very critical for survival of those who need it. So to understand this topic, as chairperson, we have with us Dr. Abhideep Choudhary. He is director and head BLK Centre for Hepatobiliary Surgery and Liver Transplantation. And sir has expertise in pediatric liver transplantation.
Yeah, he is with me
Yes,
only.
sir.
Hello,
And
everyone.
chairperson is Dr. Rachna Sharma. She is the Director Pediatric Intensive Care at BLK Center for Child Health. And as we know, timely diagnosis and good pre-transplant and post-transplant care is very critical in improving the outcomes in children.
Start, ma'am.
So let us hear from Dr. Ravi, who is Senior Consultant Pediatric Gastroenterology at BLK Center for Child Health. Over to you, Dr. Ravi.
Of BLKMAX Center for HPV Surgery and Liver Transplantation, and he is also President-elect of
Dr. Ravi, we lost you. Maybe you can switch off your video.
transplantation. It was first attempted in 1963, which was actually the liver transplant itself was done for extrahepatic biliary atresia for pediatric condition to start with. Initially the outcomes were little, the people were little skeptical because of the mortalities. Then outcome improved following the introduction of cyclosporine in 1980, and first liver transplant in children in India was performed at 1998 at Apollo Hospital, Delhi. This is Quina's segment that we usually use for hepatic anatomy, for especially for the segmental anatomy for liver transplant purposes. You can see there are different subsegments of segments of liver, especially 1 to 8. 2, 3, and 4 are especially the lateral segments, and which are liver transplant. So pediatric liver transplant, the lateral segments, what does it give is actually the lesser rate of donor complications and the lesser rate of remnant hepatic failure in donors, because the portion that we need is typically quite small for pediatric liver transplant. So what is a good liver donor? So let's start with donation of liver. So a good liver donor is someone who is healthy, who is close relative of the recipient, has a compatible blood type and body size. So these are criteria for live donation of liver that we usually practice. That the donor must be in good physical and mental health. He must be between the ages of 18 and 16, must have a body mass index that is less than 32, must have a compatible blood type with recipient, and he must be free from following disease: significant organ disease, if there is any malignancy, hepatitis, active or chronic infections, any substance abuse. So in nutshell, a donor should be healthy and he should be free from any pressure or guilt that is associated with donation. Means it should be completely voluntary donation on the donor's part. So what is the typical timeline for donor? That is, the admission is done on -1, means the 1 day prior to liver transplant. The operation time is typically between 6 to 10 hours. Usually there is on-table extubation. Donors are usually discharged on 7th day. They can resume normal usual activities by 1 month post liver transplant.
Dr. Ravi, we cannot hear you. Maybe you can switch off your video.
Indications for liver transplant. So basically, any liver disease which so they to summarize this, or to just divide into especially 5 indications. So one is there is primary liver disease that leads to hepatic insufficiency. There acute liver. There is secondary liver disease and primary hepatic malignancies. Hepatic biliary atresia. So extrahepatic biliary atresia is something that we usually encounter in our usual practice also from a pediatrician's point of view, from a pediatric surgery point of view. So everybody comes into picture when there is biliary atresia is the question. So what is once the opportunity of Kasai portoenterostomy is missed, is especially in the first 100 days, then the child becomes a candidate for primary liver transplant. So what are the primary failure of the Kasai? So especially when 3 months or more post Kasai operation, if the total bilirubin is more than 6 milligram per deciliter, that is, then you should consider the prompt referral for liver transplant evaluation. If the total bilirubin is between 2 to 6 milligram per deciliter, the LT evaluation should be considered. So when there is refractory growth failure because of the recurrent cholangitis, when there are complications of portal hypertensions like portopulmonary hypertension is there, hepatopulmonary syndrome is there, ascites is there, because of the varices there is recurrent bleeding. So all these things, they make an indication for liver transplant. And when there is progressive liver dysfunction in the in the form of synthetic failure, low albumin, the progressively increasing INR. So all those conditions, they suggest the child is going to need liver transplant. So what are the other thing is acute liver failure. As you can see in the second point is acute liver failure. So what are the what is the definition of acute liver failure? As we all know is when the INR is more than 1.5 with encephalopathy, or INR more than 2 with or without encephalopathy, is usually considered acute liver failure. So this is a figure which denotes when do you consider liver transplant in pediatric acute liver failure. So you can see there is continuous reassessment for hepatic encephalopathy, multi-organ system dysfunction, and clinical instability. In case the things become improving, the liver transplant is deferred, but at the same time you have to continuously evaluate, put scores on a regular basis, critical scores, and find out whether the child is deteriorating and maybe in need for early liver transplant. So recent guidelines regarding pediatric acute liver failure, some of the interesting points that come out now is that the degree of coagulopathy has not been shown to correlate with hepatic encephalopathy. So earlier it was like if the INR was one of the main criterion for deciding the liver transplant, but now it is multiple factors which are taken into consideration. So the PALF study group has demonstrated that 25% of the patient who had grade 3 or 4 hepatic encephalopathy and requiring intensive care only had mild coagulopathy with INR less than 2. With this degree of encephalopathy, these child continues to demonstrate highest rates of mortality irrespective of their INR values. So all patients with acute liver failure require close monitoring and daily assessment of overall mental status for this region. So recently there has been scores, liver injury unit score, which has been specifically developed for acute liver failure, and that include factors for peak total bilirubin, PTINR, and ammonia. So sensitivity and specificity were in the range of 74 and 80% respectively. If the liver injury unit score is less than 209, child is a low risk for liver transplant and usually will survive with his native liver. And if the liver injury unit score is more than 370, then there are high chances that child is going to require liver transplant. Another one is New Wilson Index, and if it is more than 11, there is requirement of liver transplant. And if Wilson disease comes with encephalopathy, usually the child requires liver transplant. And PELD is also one of the scores. So these are formulas for PELD score and LIU score. In LIU score, you can see there is peak total bilirubin, there is peak INR and peak ammonia levels, which are considered for calculating this. So what are the poor prognostic factors in the PALF? So if the child is younger than 1 year at the time of presentation, when there is presence of grade 4 encephalopathy, when the liver injury unit score is able to predict death or liver transplant by 4 weeks of patient preparation with an area under the curve of 88.5 to 90.5%. And its use in clinical setting is typically limited by the reliance on peak laboratory values rather than the trends. So King's College model also incorporates the presence of hepatic encephalopathy, which actually is unreliable feature in pediatrics, and maybe little late, you might be little late to diagnose it. So patients which are most likely to be listed for liver transplant are some which have like higher INR, median is 3, when the total bilirubin is high. That shows the extent of damage when the lactate is high, the ammonia and the liver enzymes which are falling after initial rise. Boys, when the child is requiring inotrop, there is mechanical ventilation, when there is the etiology of liver failure is not clear, when there is indeterminate pediatric acute liver failure. So resolution of the disease without transplant was more likely in patients without encephalopathy. So again, the encephalopathy is something which should now, which should be usually monitored daily and should be taken into account all the time. During all the evaluations, it should always be taken into account. So what is the negative impact of young age on PALF outcomes? So there are liver support system till the time they find donor, and when we give liver the chance to regenerate on itself, we usually incorporate some liver support system, and some of them at our center that we use is CRRT and plasma exchange, especially plasmapheresis. Usually we do it with hemodialysis or CRRT. So when the liver transplant is used as a primary therapy for inborn error of metabolism, so it is especially, I would like to mention some disorders which do not injure the liver, but the principal goal of treatment is being to correct the metabolic error which usually has a base in liver. So some of them to enumerate, there is urea cycle defects. The liver might be entirely normal, but the child will continue to have the production of excessive production of ammonia and consequent brain damage. There is Crigler-Najjar syndrome. The liver might be healthy, or albumin, INR, everything will be normal, but at the same time, because of the increase in indirect bilirubin, there might be chronic bilirubin encephalopathy, there might be CNS damage, and the continuous phototherapy as the child gets older becomes difficult to institute. Homozygous familial hypercholesterolemia, the liver might be normal other than the fatty liver, but at the same time the heart is at risk of atherosclerotic disease even in the younger children. Primary hyperexoluria, when there is the liver is normal, but the because of the oxalate production, there is because of the oxaluria, there is kidney damage. So either you do a liver transplant if it is diagnosed earlier before the kidneys are damaged, or you do the combined liver and kidney liver transplant when the kidneys are also damaged. So again, UCD is one of the important parameters. Why do we emphasize on UCD? Is because sometimes it becomes too late and the child comes with, brain damage. So the decision has to be taken earlier. There are secondary liver disease, something which are not, initiated in the liver, but later on they might involve liver, like cystic fibrosis. There is biliary cirrhosis. There might be sclerosing cholangitis, that is secondary to Langerhans cell histiocytosis. So then there are primary hepatic malignancies. The most common malignancy of those is hepatoblastoma. So earlier there was a doubt regarding whether liver transplant should be carried out initially or there is resection, which is more advantageous. But now the things are becoming clear that if the pretext staging is 4 or the tumor has some certain characteristic, then it is better to go for a primary transplant than to go for a salvage or rescue transplant. The rescue transplant, they carry a much worse prognosis than tumors uh, treated by primary transplantations. So liver transplantation that are done after a tumor has recurred in the liver carry a non-recurrence rate of 20 to 30% in comparison to the rates of greater than 90% for primary transplant. So you can see for yourself the difference is, very significant. So that is why in pretext 4, we do neoadjuvant chemotherapy. But even if the tumor is clear, we still advise primary transplant instead of extensive or complex resection of the tumor. What is the typical pre-liver transplant course? Is once the child come, we assess the etiology and need for liver transplant. We do nutritional optimization. We give multivitamins. As you all know, the child is usually deficient in fat soluble multivitamins, and for that they are given initially. They are given in higher doses. Then we manage if there are any complications to be managed before liver transplant. Some of them is portal hypertension. There might be, TENS ascites, hepatopulmonary syndrome might be there, some underlying infections. There simultaneously the donor and recipient workup is done. The clearances are taken, and it typically takes around 1 to 2 weeks depending on urgency. I would say depending on urgency, because the same things takes 24 hours, even 12 hours when the child is in ALF. But when you have time, then you need to evaluate and optimize many other things. So child is admitted on 1 day prior to liver transplant. Our usual post-transplant course at most of the centers and at our center is actually we entail the fast track approach where we extubate in the operating room itself. Then there is ICU stay of 3 to 5 days, and oral feeding usually we start between second and third day. Most of the time it is day 3 only, but the median length of hospital stay is around 15 to 20 days. On day 5 or day 7, usually the child is shifted to ward. The laboratory results are checked on a initial, for first 20 days they are checked on a daily basis. Then once the child is discharged, they are checked on a weekly basis. After discharge, the medications are tapered according to center protocol, with most patient on with a target, and we try to get most patient on calcineurin monotherapy, ideally tacrolimus, by 1 year after transplantation. Right now, the lifelong immunosuppression is the standard of care at most centers, but this might change for select group of recipients that achieve operational tolerance with stable histological characteristic and graft function. Still, this is too early to comment on those. Right now, we tell every patient that there is lifelong immunosuppression, and especially with single drug immunosuppression is something that we are going to continue. So there are late complications like biliary strictures and vascular occlusions, which usually are not that common, but we do see once in a while. There are live vaccines are prohibited until the patient is on monotherapy for at least 6 months. So there are some contraindications to liver transplantation. Some of them to mention: when there is severe pulmonary hypertension, when there is secondary organ failure, when there is presence of disease that is expected to recur after therapy. So suppose the primary tumor is somewhere else other than liver, and because of chemotherapy the liver is damaged. So we don't go for liver transplant just because the liver is damaged at present. If there is risk that the primary tumor is not taken care of, or it might recur after therapy. If the tumor is metastatic, like in cases of hepatoblastoma, when there are active mets, even after neoadjuvant chemotherapy, we might have to refuse liver transplant for those child. So survival and quality of life in children, as you know, the after the extent of CNI or immunosuppression that has been improving, after every passing year. So most of the studies now, that initial as compared to the initial survival rates of 25-year survival or 10-year survival, 20-year survival of 40, 50, now it has come to the 80s. So those are, different for different center. But now the projected 20-year survival rate for pediatric liver transplant recipient transplanted between 2007 and 2018 is 84%, and projected 30-year survival rate is 80.1%, which I consider is quite good, and there is still a scope for improvement. You can see most of the studies now, the multiple single center studies, the 20-year survival has started reaching in the range of 80s. So this is our data from BLK centers, that how our journey goes into liver transplant. So you can see from starting from the COVID time, the every passing year, the number of transplant. We now at the end of 2024, we completed our 51 liver transplant. Actually 52, but the number of patient is 51 because one patient required retransplant, and this year we haven't still included. So total number of male was 29. The number of female is 22. Less than 1 year, there were 12 children. 1 to 5 year, there were 11 children, and more than 5, there were 28 children. These are few of the indication. You can see the most common indication still remains the biliary atresia pre and post Kasai. The second most common indication in our cases were cholestatic, neonatal cholestatic disease, especially PFIC, which was followed by autoimmune hepatitis, ALF, and Wilson disease. Those were followed by other, GST, some tyrosinemia, and some other disorders. So we are now doing robotic donor left lateral hepatic, because the amount that is taken out is those were done at our center is 26. The robotic assisted was 70, and left lateral transplant, which means what anatomy, what is this is, surgeon's point that they check out every details before the child is taken up for liver transplant. So this is left lateral segment. Then they are still reduced because the child's abdomen is not sufficient to accommodate that part of liver. So that is further reduced, and after reduction, then it is put inside, especially when the child weight is less than 5 kg, dry weight is less than 5 kg. These are few of the cases that I would like to show. The one is this one is pediatric acute liver failure patient. That this he was referred to us with INR of more than 8, and the underlying cause was autoimmune liver failure. During the course of disease, the child developed interstitial nephritis. Dr. Swati was there to help us from pediatric nephrology, and then the child also developed celiac disease. He kept on having this abdominal distension in between. Then he also has this DCT positive hemolytic anemia, and continuing the CRRT, he underwent liver transplant, and he is right now he's doing quite good, and his disease is, is on single immunosuppression. It's two immunosuppression that those are going on. So this is again a liver transplant, and this case particularly emphasized the role of protocols because the child was diagnosed as a case of hepatitis A at Max Dwarka. When from Max Dwarka, this child was referred to our ICU for liver transplant. We did the liver transplant. There was, because she was in deep coma, whether she is going to be awake or not. The initial 2 days were, very that was a tense period, whether means she is going to be neurologically intact or not. Day 3, she woke up, and then you can see, then by the time day 7 or next 7 days, she was completely fine. The importance of protocol in this case is that when the explant biopsy was rechecked, then the child has which kind of disease, it shows changes of autoimmune liver failure. There was massive necrosis, and if we kept on waiting for that liver to regenerate on itself because the diagnosis was hepatitis A, then I think that would have been put the child in a serious danger of losing her life. So you can see these beautiful young girls. These are I say surviving the odds because the first one was operated for acute liver failure. There was initially the family was a little bit skeptical because she was diagnosed as hepatitis A. Then we have to, after waiting for 2-3 days, when the child continued to have this problem, this encephalopathy, she was not coming out. Then she was taken up for liver transplant, and again the second one got operated for hepatoblastoma. She became, the lost hairs, very cranky initially, but now after this, when the chemotherapy finished and the liver transplant, there was no recurrence till now. It has been like around 1 year till now, but still the AFP and the repeat PET scan, everything is normal. The third one is even, I would say, the story of grit and courage because she underwent liver failure, autoimmune liver failure. For that, the transplant was done. She developed hepatic artery thrombosis. The family and doctor, everything was, everybody was saddened that in spite of their efforts, we lost the liver. There was hepatic artery thrombosis, and she became almost the, one of the rare cases where she underwent ABO incompatible retransplant in emergency settings because there was no time for desensitization. So her grandmother came into the picture and she underwent an ABO incompatible liver transplant again. So retransplant was done, and she's doing fine right now. So sometimes when our female intensivists, their motherly instinct, they come up and they forget that whether they are doctor or they are mother, and they come into picture all the time. This you can see the color of the baby, which has turned from yellow to white. It was again the case of PFIC, underwent liver transplant because of the severe itching and especially the rising bilirubin and the growth failure. So this especially babies, the parents were very skeptical of height because he was from Pathan family, and that you can see in the earlier photo, he was very small. He has recurrent cholangitis. There was CD, this congenital hepatic fibrosis with cholangitic variant. The liver was damaged, but because of the growth issues, we have to undertake liver transplant little earlier than we suggested to the parents. And 1 year post liver transplant, his growth was quite phenomenal, and you can see in the photo. This one was the youngest at our center. He was 4 months old. When he underwent liver transplant, he developed ascites early. He has biliary atresia, but somehow decompensated quite early and has to undergo liver transplant as for 4.5 months. And You can see he says that I'm no more infant now. This child, he was Wilson disease patient. He has problem with walking and standing, little problem with walking and standing, like not stabilizing. But he has a decompensated liver disease also secondary to Wilson disease. So sometimes you get more than you ask. So problems were actually halted. I don't know about how significant the improvement is going on. Improvement is going to be in the future, but for now, it seems like that the problems have halted and they are not progressing. So this is a story of from being scared to sporty. When this child came, she was scared. She was very sensitive child, underwent liver transplant, then developed, simple complications like rejection. And later on, as she, stayed with us, she developed she became quite sporty, and we could spend, little more time with him. We could pot around him. So you can see there is birthday in LT. So what if it is in ICU? But a birthday is birthday. That means for parents, that means for the boy. These are few of the other babies which, underwent liver transplant. So before we wrap up the this presentation, we can never conclude this without this baby. She came to us with severe HPS, with, saturation of SpO2 between 40 to 50%, with severe drumstick clubbing. She, we were always in a fix whenever after doing liver transplant, the hemoglobin reached to 16 in 1 day or 2 day. Every time we do let down, the hemoglobin will, spike up because of the hypoxia. And we don't want our arteries, newly anastomosed arteries, to be coagulated because of the hemoglobin. We undertook measures for, anticoagulation on the extreme side, at the same time, letting down the blood again and again. And we lost that baby to a enterocolitis there, because the doctors were fixated on this saturation rather than the dehydration. So in spite of all that, the family was quite grateful that they have some moments to, some happy moments to cherish. And we are also blessed to have this, she gave us so much affection also. So this was the baby who came on wheelchair for liver transplant, but she became fine with medicines. She was diagnosed as ascites and this Budd-Chiari syndrome. And later on, as you know, we started the medical management. She showed good recovery, and we postponed the transplant. And then she is fine. She was mocking us because we told her that she needs to undergo liver transplant, and later on we told her that she doesn't need a transplant. This was the baby after our this calamity in this with the prior patient. We became more vigilant, and then we tried to, in contact with the parents and from Uganda. So this baby, again, ACLF, very sick patients, came to us with a INR unrecordable enterococci in blood. And she had a dystonia even after liver transplant. So never underestimate the power of physiotherapy. You can see now she doesn't have any dystonia or anything else. We were initially worried that this might be the, neurological outcome, because she was encephalopathic earlier. But our neurologist, Dr. Rajni Farmania, and his team and her team, they took care of that problem. So this baby, she came because she has this ascites. She was post Kasai. She was difficulty in standing because of the progressive distension of abdomen, and now she is learning Indian dance now. And she got audiences because we are the audiences for her. She is also now learning to walk. You can see now, who calls the shots here. So I'll conclude the presentation, because, the prediction is the food of, the that we are going for our, ego and will to modify future. So now know the it is much better. So a devotee is like a kite who surrenders to the unseen when questions are invited. If there are any questions, you can put them. I would ask Rachna ma'am to share her experience of managing
Hi, good afternoon, everybody.
PICU. Many times she has, done wonderful job of keeping them on thiopenton and kind of, deep anesthesia, and then they come out without without needing liver transplant.
So thank you, Dr. Ravi. It was a beautiful presentation. So I would say that again, I would enforce that acute liver failure with higher states of encephalopathy has a very high mortality. But I think the two important messages which I would like to give here is that such children with acute liver failure with encephalopathy, they should be treated in a center where we have facilities for liver transplant. And plus obviously the ICU. So whenever these children are coming to our ICU, our role is to provide the supportive therapy as a bridge to transplant. Because ultimately the mortality is very high without transplant. And the only chance which we can give to these children is by, by taking them for liver transplant. But there are few kids who can do without liver transplant, but this will not be possible without supportive therapy. Now, supportive therapy in the form of CRRT, that is continuous renal replacement therapy, and plasmapheresis, and obviously the other ventilatory support, inotropic support, neuroprotective support. All this multidisciplinary support is required either to recovery or to transplant. So I think we are fortunate to have a very good team with us in the form of subspecialists like Dr. Swati, who's there to support from a nephrology side for CRRT. Then we have very good people in our blood bank who are there to support us for plasmapheresis, and obviously the liver transplant team and Dr. Ravi Bhardwaj is always there to guide us. And Dr. Abhideep, we have full confidence in him. So we are able to do like our children have been able to do well wherever we could do. But fortunately, we had few kids who were able to survive without liver transplant also. So I think the most important thing is supportive therapy that needs to be given in the setting of liver transplant.
Okay, ma'am. Thank you. Swati ma'am, can you unmute and just
Maybe
ask
we
if there
also
are
hear
any?
from Abhideep sir about challenges in pediatric surgical challenges in pediatric liver transplantation. Particularly, you have shown a lot of young infants who were very sick and undergone liver transplantation. So, sir, could you share your experience?
Yeah, hi, good afternoon all. I mean, Ravi actually covered pretty much everything, but thing I would like to say is pediatric liver transplant is actually much more complex compared to adult liver transplant. And how I look at is this is one field where uh, innovation, teamwork, and compassion intersect. And definitely over the years, we had significant advances in surgical techniques. I remember when I started doing pediatric liver transplant in 2008-9. A lot of time we used to have large for size problems. Even if we were taking a left lateral segment, it was too big for the baby's belly. So what we used to do was we used to put the vacuum dressings and keep the belly open, and once the liver used to shrink, then we used to close the skin. And once the baby used to grow, then we would go back and repair the hernia. But now, over last 8-9 years, what we have been doing is we are reducing or hyper reducing the graft and even going up to a mono segment graft, where as per need of the baby, we just take a single segment. And that is basically, I would say, a totally surgical advance in terms of able to identify a single segment with all its inflows, outflows, and biliary tract. And with the help of our radiologist, intervention radiologist, who actually helps us in intra-op mapping of these structures, so that however small the baby is, the smallest baby we have done is 4.5 kg with hardly any space in the belly, and we could easily close the muscle and all. So that is something, and that helps us in extubating the babies on table, and the chances of respiratory problems and prolonged ventilation is actually gone. So that is one of the major technical advance. But then more than that, what has progressed a lot is the peri-op care, the ICU management, the medical management, the long-term, multidisciplinary long-term support to these young kids, which involves not just the clinicians, but also the nutrition, the physiotherapy, which actually brings them back to absolutely normal life. And we have now some kids who have actually, now I cannot call them kids, they are grown up and they're in their colleges and doing very well. So that is something I would say has changed. I mean, if I look at my 15-year experience of doing pediatric transplants, a lot has changed over this period, and the way teams have developed and working on these patients together, that has helped in getting those results. But despite this, I still feel there are small challenges which we need to work on. Those are the timely referral of these patients. And I completely agree with Dr. Rachna, particularly patients like ELF should immediately be transferred to the center which has all the facilities if we have to do a medical management or a surgery, because delayed referral leads to losing these kids. And then identifying the donors, and people have to now accept this. I mean, Ravi has shown 80% 10-year, I would say it is now more than that, survival. So people should not be scared of talking about transplant. And definitely long-term care, and once these kids are back to their normal life and they go to any setups, I mean, they should not be looked at something special or something different from normal population. The care should be given as to be given to any other kid. And only extra thing is they require a little bit dose of immunosuppression. Pediatric patients, they require much lesser dose of immunosuppression compared to adults. So I think these are certain things which we have over a period of time realized, and now we are working on the tolerance protocols where we are actually bringing down the immunosuppression, particularly when the livers come from parents, and we are able to minimize the immunosuppression significantly. And I think going forward, if we get some more information and knowledge about tolerance, maybe we will be able to keep these kids completely off immunosuppression, and that is what I think the world is trying to achieve in terms of pediatric transplant. So I think it was a fantastic interaction and the presentation, and I'm happy to be part of it. Thank you.
Thank you so
Thank
much
you,
sir,
sir.
for sharing your experience. It's really encouraging to hear that. Dr. Ravi, I have one question for you. Are there some diseases which recur in the graft after the liver transplantation?
Yeah, so especially the autoimmune hepatitis and PFIC2 are something which have been known to recur in, PFIC2, there are 10%, chances that the disease might recur in the liver, in the new liver. But again, that is because of those antibodies, again, BSEP, the bile salt exporter protein. So pump. So the antibodies, they typically come again when the immunosuppression is decreased. So when the most of those patients are, managed medically, like with the help of IVIG, with the help of plasmapheresis, with the help of increasing the immunosuppression. So everything of, the sort of those, depending on how severe is those recurrence. And especially for autoimmune hepatitis also, because there are chances of recurrence, that is why we usually keep the, low dose steroid. We continue with the low dose steroid for longer time, even sometimes, lifetime, just because there is risk of, recurrence of the original disease. So these two diseases, especially in pediatric, they recur. Other something that is not very common is autoimmune hepatitis, autoimmune sclerosing cholangitis complex. Then again, this is related to that only, AIH only. So these are diseases which usually recur. Other than that, most of the metabolic disease, they don't recur. Some of them might not have, like 100% cure with liver transplant, but the child gets benefit, especially in cases of MSUD and the organic acidemias.
Okay. And one more thing, are we also doing cadaveric liver transplants or any other center in Delhi which is doing?
Means see, live donation, living donor liver transplant is, I would say, is complex as compared to cadaveric. So cadaveric, if this cadaveric donor is available, then definitely we do, but we haven't find anyone. Means there was one transplant that was being done in last so many years that was also not for pediatric.
Thank you, Dr. Ravi. So if anyone from the audience has any question, you can please unmute yourselves and ask. We do not have any questions in the chat box. So if there are no more questions, we would conclude this session. First of all, thank you, Dr. Ravi, for such an informative presentation. It's really encouraging to see how liver transplant can transform the lives and provide a new lease of life to these young patients. And I also thank our chairpersons for taking out the time and sharing their expertise and experience with us. And lastly, thank you to all the audience. And we take leave now, and next month we will be back with another interesting topic in the BLK Tele series. Thank you, everyone.
Thank you, ma'am. Thank you, everyone.